Like, it's like being in church and you don't want to laugh, and then it just makes the laugh like 10 times worse.
I also heard that a sneeze is like 1/16 of an orgasm.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
ECMO, let's talk about ECMO.
No, I want to ask you a question.
Oh, you got questions, okay.
Well, we're going to lead into ECMO.
Oh, okay.
But I'm just curious, do you know what the 3 most deadly diseases are?
3 most deadly, now are we talking I
was reading about the top 10 most deadly diseases.
Like, are we talking
kills
about
the most
heart
people.
disease? Is that?
That's number 1, yeah.
Oh, okay.
The heart disease is by far number 1. I mean, it's like you add up all the
Especially in
traumas and
America.
cancers, it won't even equal that.
And Whataburgers.
So that's number 1,
Okay.
the number 1 greatest killer. And
Heart disease?
it's a trick question. So number 2 is stroke, but they consider that a cardiovascular
I was wondering
disease. So
about
that's
stroke.
together. So number 1 and 2 are kind of, kissing cousins. Is that the right term?
Sure. Never mind. I'm not going to say
Kentucky?
it. I was going to say Kentucky too. That's so bad.
I got a sister that lives in Kentucky, so I feel like I can say
I love
that. I love
I've been to
Kentucky.
Kentucky. It's a beautiful place.
Yeah.
Number 3 is trauma. I don't know.
No.
I thought maybe they'd list trauma as a disease.
Well, because those are both stroke
Yeah.
and heart disease are cardiovascular diseases. Number 3
Sepsis.
surprised me, and I haven't verified the data, but lower respiratory infections, pneumonias and things like that.
Okay, yeah.
Yeah, that's the number 3.
Well, you think about older people, nursing homes, they get pneumonia. Yeah. Okay.
Yeah. So
Interesting.
now how do we get to ECMO from there? Well, some of the most deadly diseases we treat that we can make a difference in, I think, are cardiac arrest patients. We talked about this in our cardiac arrest lecture we did a couple weeks ago.
Yep.
The survival rate of out-of-hospital CPR or cardiac arrest is about 9.1% in adults, 11.4% in kids, I think we talked about.
Yep.
Out of hospital. In hospital, different game.
Yeah.
But out of hospital where we work, less than 10% of our patients are surviving. And so we'll get to ECMO because I think ECMO is so exciting because now we could take this patient demographic, a portion of them, we'll talk about it, and we can save a whole lot of lives by using this technology, this amazing technology, ECMO. And it's been around a long time, but
since
now
the 90s, right?
Yeah.
Yeah, they've been using it on little kids. Yeah.
I know when I was back when the earth was young and in my training, we were using ECMO for little babies with cardiac abnormalities where we had to bypass the circulation in the lungs to,
Fix the heart.
transplant or whatever we had to do. It was a life-saving piece of machinery. It's amazing what it does.
Yeah, it's a simple machine from what I understand, but I mean, small, portable. They use it in helicopters. We talked to a flight nurse, and she said it's really neat to watch.
Well, and ECMO, extracorporeal, which means outside the body.
Right. Membrane oxygenation. Yep.
So basically what you're doing is you're bypassing your lungs and your heart.
Yep.
And the machinery is oxygenating the blood and pulling the CO2 out and adding the oxygen and reheating it too.
Yeah,
There's a bit of heat component to it and putting it back into the body. And that gives the lungs and the heart a chance to recuperate or do whatever you need to do while you maintain oxygenation of other vital organs like your brain.
Yeah. Specifically.
Yeah. So that's what ECMO is. And I don't think we need to jump in and geek out on that.
No, I think we're going to have some other parts where we're going to bring in some people. And talk to some experts.
Yeah, this is part 1, kind of an introductory thing.
But I think this one we were going to talk a little bit about, not a little bit about, but mainly focus on because our audience
pre-hospital.
is mostly pre-hospital providers. And how does this change what we do in the field?
Because it doesn't, the little intricacies of how ECMO works. I mean, that's cool.
Yeah.
And it's fun to geek out on that stuff, but it doesn't really matter.
To us. Yeah, because we're not. Now, I will say that we recently started doing ECMO in my department, and we've had one crew, and I mean really recently started doing it. We've had one crew take a patient down there, and they said what was really neat, and what I think is really neat, and maybe we could talk about this, is how much more accepted the pre-hospital providers are becoming by the hospital providers. Back when I started as an EMT paramedic, the nurses didn't really care for us much. They didn't. A lot of older generation nurses, maybe even physicians, didn't really see EMTs and paramedics as real providers.
Right.
And now they're realizing the dramatic impact that we have on the healthcare system as a whole, and they're like, we're doing a lot of really good things.
If that doesn't get you excited?
Have a massive impact on patient outcomes, massive impact. I think ECMO is another new part of that. Yep. And so when this crew specifically got down to this facility, they made that crew part of the ECMO team when they got there, and they were helping them do stuff. They still had them on their Lucas device. And it was really neat. It's really been a neat thing to experience.
I think it'd be worth briefly discussing some of what, now, I know we've been using ECMO a long time, but I think what was really brought ECMO to the forefront was COVID.
For sure.
I think, and when you get COVID, we're not going to dig deep into this, but you're really just shooting your lungs to hell.
Right.
It's really what you're doing. Right. And it's not the COVID virus, the coronavirus, or the, whatever. That's what it is. It's a coronavirus. It's not the virus that really causes the problem. It's your body's inflammatory response to it and the fight that happens to kill it.
It's like anaphylaxis.
It binds to the pneumocytes, and that's where the battle takes place, and we destroy our lung tissue. And remember, we talked about this in previous lectures. It's our lung tissue. If you've laid out all those alveoli flat, and it'd be the surface area of a tennis court, one cell thick. And underneath that cell thick membrane would be 6,500 kilometers of tiny little blood vessels exchanging gases through. I mean, it's just an amazing interface. So, an amazing organ, right? And we talked about this on our CE lectures, right? Phenomenal. I mean, just amazing pathophysiology. It's incredible. But the point is that when COVID would destroy the lung tissue, the vast majority of folks on the ventilator were dying because of the barotrauma of the ventilator and the diseased lung organs, the alveoli that were diseased and munched up. And so by putting folks on ECMO, you bypass the lungs, let them heal while you're using the ECMO to oxygenate and remove the carbon dioxide from the blood, and you're able to give the lungs a break. And the heart a break too, I suppose. You can look at it that way as well. And because that's the benefit in cardiac arrest, right? Same thing, same sort of philosophy. Usually what kills people, let me say, why do people go into cardiac arrest? Medical cardiac arrest, what is usually what's going on?
Pump problem.
Usually pump problem. And so usually the pump is diseased and it needs to be fixed. And somebody in cardiac arrest, we're only surviving, only about 9.1% of these folks are surviving without a hospital cardiac arrest. When you grab the right patients and you select them and you put them on ECMO, fix the heart, and these folks are leaving the hospital
neurologically
intact at a much higher rate than
50%.
Well, that's the current, right?
Current data is saying 50% or better.
Right, and ECMO doesn't mean you're going to live. It just, what I was reading today, an article that came out in GEMS, it looks like about 50% survival rate when you're on ECMO. So half the people die on ECMO. But when you're looking at what's less than 10% survival.
Exactly. Now, if that's you or somebody you love, I'm taking those odds all day long.
Right. So I think that's significant. That's exciting.
It is exciting, and I think we should be excited as first responders, as firefighters, EMS. Our number one job in the fire service is to save lives. That is our number one job over, property. All that other stuff is secondary to saving people's lives. And, that's not just from fires. That's not just from car accidents. I would say I know for a fact that I have had a greater impact working in people's lives as a paramedic than I have a firefighter. I can remember one fire that I have been on where somebody was pulled out of a burning building. One in 18 plus years. I've had numerous in my department, numerous CPR saves, numerous people who have come back, from kids all the way to older people, So if that's our goal, we should be super excited about ECMO. And what's our role in ECMO? And it's not really, it does change how we work CPRs. And there's lots of things like you were talking about. There's lots of reasons why somebody gets put on ECMO, respiratory problems, COVID, things of that nature, but we're specifically talking pre-hospitally with the CPR patient, the cardiac arrest patient, and And to qualify, we're not talking about the 90-year-old male in a nursing home that's had a stroke and has no quality of life. That's not a patient in ECMO. In my department, we studied it when we launched it. And in 2022, we had 152 cardiac arrests throughout my city. And we looked, and only 12 of those patients would have met the ECMO criteria. Yep. And there's a lot of different criterias out there. You have one here.
And I don't think this is from on the East Coast, but and we're here in Texas and in California. I mean, things are going to be a little bit different, but I think the basic stuff, from what I can tell, is pretty consistent.
Yes.
I mean, it's got to be a
age range, witness
cardiac arrest,
Yep.
bystander CPR.
Yeah, ours is within 5 minutes.
Yes. So why would they include that? Well, I think it's pretty obvious. We've talked about this in our cardiac arrest lectures. When you have bystander CPR and you start that early, you decrease that slope of death. And it improves survival.
It keeps that brain perfused, which again, ultimately, we're going to get the heart beating again. But if the brain's dead, then what's the point? You start that circulation early. You're keeping that brain perfused. You're buying time.
But there's a chance, right? Always a chance. So we should always do ECMO, right? With every cardiac arrest.
Yeah.
Well, why don't we do that?
Well, the problem is we actually were looking at launching ECMO prior to COVID. But then COVID hit, and every ECMO machine in the country was being used, and there was waiting lists to get on ECMO.
Limited resources.
And so, there's not a ton of ECMO facilities. There's not a ton of. There's not an unlimited amount. I mean, heck, we were running out of ventilators during COVID. You know, if you put every single person on ECMO, and two, like I was listening to a podcast about ECMO, and it was talking to a physician that does this, and the other side of it too is that you don't want to put a patient that isn't going to live past ECMO on ECMO.
Right.
Because they were saying that it's very difficult. You have grandma or grandpa that you put on ECMO, and now grandma and grandpa are awake, and the family's thinking, oh, this is fantastic. And you have to now go in and explain to the family that the only reason why they're awake is because they're on ECMO, and the minute we take them off, they're not going to live out. So, not everybody needs to be on it.
And I think when you look at the data, the survival rates are XYZ, and we're not going to be talking about a lot of that now, but when you get over a certain age, the utility of putting somebody on ECMO. So it's a real fluid sort of a criteria that different agencies will employ, only because in certain communities there may only be X number of ECMO, opportunities, facilities. Whereas in maybe some other metropolitan areas, like here we are in Dallas, we've got fourth largest metroplex in the country. We've got multiple sites that are doing ECMO.
Right.
So maybe we can handle more. When you look from a population health perspective, what is the chance of somebody going into cardiac arrest, and which of these patients would be viable?
Right.
We may be able to capture a larger portion, which would impact what our criteria would be. So that's kind of why we're not getting into the details of the criteria, but the criteria will usually relate to survivability, which is going to relate to, was it witnessed cardiac arrest? Was there bystander CPR? And we talked a little bit about being in an initial shockable rhythm, PEA greater than rate of XYZ. 20 is what I use in our protocols, but and then age is another thing.
And a lot of the age is kind of subjective. I know they were telling us about a case at a local city here where the patient was, I want to say he was like 72 or 73 years old, but he was a very fit 72, 73. Went to his gym like he did every morning, was on the treadmill and collapsed. The gym staff recognized he collapsed. So it was witnessed. They were all CPR trained. They recognized he was in cardiac arrest. They immediately began compressions. The crew got there. The firefighters, and this is kind of what we're going to address today, is what do we need to be looking for? They recognized, geez, this guy's a little bit outside of the age range, but they wouldn't have looked at this guy and thought he was 73 years old. He looked very fit because he kept himself in shape. All the other factors were in place. They called the ECMO team. They said, hey, this is what we got. They said, bring him. We'll try it. They brought the guy there. All the other indicators were there. That guy walked out of the hospital neurologically intact like a week later.
There was another case, a 46-year-old patient was not witnessed, but because of his age and because of the way he appeared, they decided, let's go for it.
Give it a shot.
Walked out of the hospital.
So it's really neat.
Yep.
And like you said, there's a lot of that inclusion criteria. Is there any more that you
Well,
want?
a couple other things. I mean, you mentioned living independently. That's a factor. Going to a nursing home for
Yeah.
a 90-year-old who's bedridden.
Yeah.
I mean, it's not that life is less valuable.
No.
It's just that the chances of survival are so low that utilizing the resource of ECMO, it's a limited thing. You want to have the highest chance of survival. It's almost like triage, right?
Yeah, it's post-ECMO. Is this patient going to have a quality of life? ECMO is not a forever solution. It's a bridge to a transplant. It's a bridge to recover, putting in a cath or whatever. And is that person going to have a quality of life afterwards? Even if you had a 50-year-old that maybe suffered a stroke or had a massive head trauma and has no quality of life, is on a ventilator, like that person doesn't have the reserves to survive a cardiac arrest, and you put them on ECMO. So they have to be selective of who they put it on. But that is very subjective. Like I say, you might have a 75-year-old that really meets the criteria and a 50-year-old that doesn't because of their comorbidities and so on.
And you could have a 22-year-old that meets criteria that, depending upon the region you're in, may not meet criteria. I mean, there's a little bit of, wiggle room.
Subjectivity to the criteria.
And in this particular agency, they would communicate with the facility and even discuss it with the physician potentially within the first 10 minutes.
That's what So everybody's a little bit different in how they do it. So ours, we have an inclusion criteria, and I think it's important that we talk about how does this change our response as pre-hospital providers. Because for years, we have been really hammering on stop rushing to the ambulance in a cardiac arrest situation. We've been talking about this, especially like PD patients. Dose of diesel, right? Well, in this situation, timely dose of diesel is what they need because there is a window, a time frame that's anywhere from 30 to 45 minutes.
30 minutes here, and I think 45.
45 for us, so it depends. On whatever each individual inclusion criteria is, but there is a time window, and we have to abide by that. And so we can't spend 20 minutes on scene working a code if I have a 20-minute transport time. That's not going to work. So we have to, as pre-hospital providers, we have to be thinking about this when we get toned out to a CPR. We've got to have ECMO on our brain, and when we get in the ambulance and we're looking at the notes, we have to be thinking, just based on the notes, okay, am I going to an assisted living facility, a nursing home?
Don't worry about ECMO.
The ECMO is probably not going to be probably not going to be a candidate, right? Is the patient 90 years old? Are they, of an extreme age? Does it say that they're a cancer patient or something like that? Or is it saying 55-year-old male, wife called, husband just collapsed? Oh, okay, interesting. So the call that we actually had in my department was it actually came in as a seizure call, was what they originally got called to. And right before they arrived on scene, they were notified by dispatch that it was now a CPR in progress. Luckily, there was a very alert paramedic on scene that when he got in, recognized the patient was very young and started realizing that all the other indicators were there and quickly made that assessment. And so that, I think, is the biggest thing for us as pre-hospital providers is if you're a medic on the box, you're looking at your notes, you're keeping ECMO in your mind. Like you said, if we're going to a nursing home, probably not an ECMO candidate. Looking at the age, 55, 50-year-old male, 60-year-old male collapsed.
Staff at the nursing home.
Staff at the nursing home, maybe, this might be an ECMO candidate. Then my priority when I'm getting on scene as the medic is my patient meeting that criteria? Are they in a shockable rhythm? Maybe the officer's talking to the bystanders. Did someone witness the collapse? Did somebody get on the chest within 5 minutes? So on and so forth. And then quickly making that determination, okay, hey, this is an ECMO candidate. Now what do I got to do? Put in a supraglottic airway, throw on whatever kind of mechanical compression device you have, Lucas device or auto pulse or whatever, get them loaded up and start heading to the hospital. Now, a lot of that too will depend on, if you work in a major urban area, you might be only 5 minutes from an ECMO center, but I would assume that most people probably are going to be a little bit further out. We're 15 to 20 minutes probably from our closest ECMO center. So I've really got to be cognizant about my time on scene, and I got to get there because that 30-minute or 45-minute is from the time the patient went down to when they arrive at that facility.
Yep.
It's not a when we arrive on scene.
Yep.
You know, so we have to really be thinking about ECMO en route to the call once we get on scene, and then we have to make that determination quickly and get moving.
And it really makes sense that we optimize our on-scene time with some of these situations, in that we're not doing anything they can't do there.
Right.
But if we have a situation where they can do something we can't do, you know, whether it's like a trauma, blood products,
exactly,
or surgery with surgical emergency, or whatever, we got to load and go.
Yeah.
And so this is one of those situations. We're smart.
Yep.
We can identify the situation, identify a potential candidate, load and go.
Now in Europe, they've been doing this for years in the field. These ECMO teams and surgeons, there's a really neat picture when it was presented to us. I told you about this, and I thought it was really cool, of the ECMO team doing an ECMO procedure at the floor of the Louvre. I mean, it's just like that. This picture is amazing to me. But yeah, they've been doing it in Europe for years in the field. And there's places that have ECMO teams that are doing more mobile, and I think that's going to become more and more common because it just does show real promise for having super high success rates.
You know, it's just, if you could just step back for just a moment and think about what's going on here. You know, it wasn't that long ago that we were treating sore throats with kerosene.
Yeah. Or baldness with, what was it? Sap from a cherry tree?
Yeah, a grapevine. Yeah, whatever. But man, the medicine in the last century has just exploded.
Yeah.
And the fact that we, in the pre-hospital environment, can identify patients that we can bypass their circulatory system and keep them alive and go from a 10% mortality rate all the way up to maybe even close to 50%. I mean,
amazing.
That is amazing.
And you think about just in the last, 30, 40, 50 years that EMS has been around.
Yep.
And we used to just be ambulance drivers and a taxi service. And now you look at the complicated things that we're learning and doing in the field, finger thoracostomies and identifying ECMO patients. I mean, it's amazing. It's exciting. I find it exciting. It's really neat. This ECMO thing is really neat to me.
I think this should get all of us excited.
Yeah.
This is really cool.
When you have that high a percentage of saving lives, that much higher percentage of saving a life, I think we should all be excited about that.
Well, I think this was a good intro to ECMO and the physiology of sneezing and
yawning.
That was good. It was a good intro. So we talk about ECMO. We talk about what it is, just surface level.
Yeah. And our follow-up, we'll talk to some people, like I said, that do this and give us some more data and kind of see this a little bit more firsthand. Be cool.
And if you're listening to this and I know we get a lot, all over the country.
Yeah.
We've got our students. And you don't have an ECMO program and you hear about it, get excited about it.
Yeah.
Don't be afraid. This is just something that saves lives.
Yep.
And being part of it, I think we have a responsibility. If there's something we can do to improve mortality this significantly,
absolutely,
something we need to get on board with.
For sure.
Yeah. Man, it's great talking about this stuff.
Yeah.
I'm looking forward to part 2. This is really good.
Cool. It is the weirdest thing that, like, as soon as he starts rolling, like, we'll be having a conversation, everything's fine. As soon as we start filming a podcast or sees, I start getting this overwhelming urge to just want to go, and it's like being in church and you don't want to laugh, and then it just makes the laugh like 10 times more.
Do I bore you?
No, it's not that at all. I don't know what it is, but it's this thing where it's like, and I'm sitting here holding it. Have you ever tried to hold back a yawn?
Were you shooting up some heroin? Because that makes the opiates make you yawn.
I wish. No, I don't.
Take a Norco on the side?
Yeah. Smoking a little of the,
Yawns are contagious. I don't know why.
I know.
When I'm having a meeting with one of my colleagues.
You just yawn to make them yawn?
Well, because I feel like I'm always tired. And,
yes.
And I'll yawn, and then I could see them fighting it, and I'm like, I know
their
it's coming.
eyes are
and I'm like, I'm sometimes I'll fake yawn, just to make him yawn,
that's
and
funny.
it works every time,
Yes.
and I don't think he realizes it.
And you just keep doing it to the same guy.
Yawning is so funny.
Well, now I'm going to do it on video.
We're not
so that
talking
you
about yawning today.
Yeah, no, we're not talking about yawning.
But go ahead and yawn.
No, I don't need to do it yet because we're laughing. I don't know what it is.
It's kind of like sneezing.
As soon as you get off into the weeds, well, then you can say purple, and that ends the sneeze.
Sneeze purple?
Oh, yeah. If you got to sneeze, just say purple.
Well, I just say bless you before I can see somebody's like, and I'll say bless you.
Yeah,
and
and then
you stole my sneeze.
Yeah.
also heard that a sneeze is like 1/16 of an orgasm. It's like there's a pleasure to it, I guess. I mean,
Well,
I think
it is-
sneezes feel good.
Or, well, I won't get off there.
I don't know why I
so
said
I
that.
had
I shouldn't have
hiccups
said that. Debbie's
really
gonna-
bad one time on a call. I was transporting this lady to the hospital,
Yeah.
and for some reason I got the hiccups. And I mean, they were persistent. They would not go away. And the whole time I'm hiccuping and I'm trying to do my thing. We get to the hospital, and as we're walking in the room, she stops. And she goes, "You're having a hard time getting rid of this." I'm like, "I'm so sorry," you know, and I'm doing this. I'm like, "I'm so sorry." And she goes, "No."
Was it that frequent? That like
Not that frequent, but it was consistent.
Yeah,
I mean,
yeah,
I was trying to hold my breath, everything. She goes, no, look in my eyes. On the count of 3, your hiccups will be gone. 1, 2, 3. And I swear to God, like that.
I'd fake hiccup.
No, it was so crazy. Just like
worked?
that.
It worked?
She goes, "That's an old Indian trick." And I'm like, "Are you
really?
kidding me?" And she goes, "Yeah, you just got to like redirect your brain, lock in on my eyes and count." And literally, I stopped hiccuping.
You know what I do?
What?
I scare people. I scare them like I'll smash the table.
Well, that would work. I'm going to call you the next time
I also hear
have
if you
hiccups.
drink upside down.
I've done that. I've done the straw under the tongue.
Oh yeah?
Yeah, all kinds of
Wait,
weird
wait,
stuff.
straw under the tongue?
I've heard if you put a straw under your tongue and then you drink until you... I think it's all just a redirection of your brain. I really think that's...
Kind of reminds me of the Vitology book, you know,
Yes.
curing baldness with sap from a grape tree or something
Yes,
like that.
laying down with your knees up to your chest. I've done that, and that's actually worked for me.
For baldness?
For baldness and hiccups. Obviously, it didn't work very well. It obviously worked for
Love
you.
you like a brother, man.
All right, let's talk about a cool...
Well, real quick though.
Oh, what do you got?
Well,
I'm about to yawn. What do you got?
well, you know, you can steal a sneeze, right?
Okay, yeah.
But hiccups, though, you know,
I wish
they
you could
hurt,
steal my...
and
Oh,
they,
so frustrating.
yeah, we have it's an ER chief
Yes.
complaint. People will come into the ER because they can't stop hiccuping.
For
It's a
days.
it can really
That will
cause
drive
pain.
you insane.
Yeah.
Oh,
it
can
hurt.
you imagine like trying to sleep and just doing this every... Oh,
And sneezing can be detrimental too.
Horrible.
There's this tremendous amount of force with the sneeze.
Yes.
And those
similar to an orgasm, you said once.
1/16. That's what
Of the force.
I don't know. Well, let's measure that. We'll design a study.
How do we design that
We are
study?
going in the wrong direction.
We're
here,
going
Matt.
off in the weeds
Wrong
big